Welcome to the deep dive. Today we're looking into a really significant area within organ transplantation. Specifically, a complication that, well, it can sometimes follow an orthotopic liver transplant, or OLT.
Exactly.
Yeah.
We're focusing on some recent research that's trying to, get a better handle on predicting something called persistent acute kidney injury, or PAKI, in people who've received a new liver.
Right. And our guide for this is a study called Development of a Prediction Index for Persistent Acute Kidney Injury Following Orthotopic Liver Transplant. Came out this year in the Annals of Hepatology. Think of this as sort of your clear guide to understanding the key factors, the risks involved, and the tools being developed to, well, tackle this challenge.
Yeah, our mission is pretty straightforward. Just distill the main findings from this research.
Make it clear for you, the listener.
Exactly. Make it clear who's most likely to get PAKI after a liver transplant, and really crucially, why this matters for their long-term health.
Okay, let's unpack this then. So what's the basic problem we're talking about here? The study highlights that acute kidney injury, AKI, is actually pretty common after a liver transplant.
It really is, yeah. The study mentions that some research shows AKI happening in, well, a large chunk of liver transplant patients. Rates like 40 to 70% sometimes.
Wow, that's high.
It is. It's a frequent issue, and why it happens is complex, lots of factors playing together that we're still figuring out.
Okay, but this study, it zooms in on persistent AKI, PKI. How's that different from just regular AKI?
So PKI, the way they define it here is AKI that lasts for more than 72 hours after the transplant surgery.
72 hours.
Yeah, and that persistence gets the key bit because it's linked to worse outcomes, not just right after surgery, but down the road too.
Right, longer term. So let's talk about the study itself. Where did they do this research? Who was involved?
Okay, so this was a retrospective study. They looked back at patient records. It was done at a big medical center in Mexico City, the Instituto Nacional de Ciencias Médicas y Nutrición Salvador Zuberon.
Okay.
And they looked at 305 adult patients who got a liver transplant from a deceased donor, a cadaveric transplant between 2008 and 2018.
Were there patients they specifically didn't include?
Yes, definitely. They excluded people who already had advanced chronic kidney disease before the transplant.
Okay, makes sense.
And anyone who'd had a kidney transplant before, or importantly, anyone who already had AKI when they were admitted for the liver transplant itself.
Right, so they wanted to isolate kidney injury that happened after the procedure.
Exactly. That was the focus.
And what were the main goals? What do they want to find out?
Two main things, really. First, figure out what factors make someone more likely to develop this persistent AKI after the transplant.
Right.
And second, use those factors to create a tool, like a risk index, to predict it.
A prediction tool.
Yeah. And they also looked at how PAKI affected things like mortality and kidney function over the next 5 years.
All right, so let's get to the findings. How many patients actually developed PAKI in this group?
So out of the 305 patients, they found that 23% developed PAKI.
23%. That's nearly 1 in 4.
Yeah.
Seems pretty significant.
It is a significant number.
Okay, now the big question. The risk factors. What did the study identify? What makes someone more likely to get PAKI?
Right. So after all their statistical analysis, they found a few key things. Being male was one factor, needing another operation or reoperation after the first transplant surgery.
Okay.
Also, getting a lot of blood transfusions during the transplant, specifically more than 6 units of red blood cells.
6 units, got it.
And then something called the anhepatic time. That's the time during surgery when the old liver is out, but the new one isn't working yet.
Right.
If that time was longer than 50 minutes, that was a risk factor.
Over 50 minutes.
Okay.
And was there one more?
Yes. The last one was needing a specific medication, norepinephrine, around the time of surgery. If they needed a dose higher than 0.25 micrograms per kilogram per minute.
Norepinephrine. That's for blood pressure support, right?
Exactly. It's often used in these big surgeries, and needing a higher dose might suggest the patient was, less stable hemodynamically.
That's a very specific list. So how did they turn those factors into a usable prediction tool?
Right. That's the risk index. So based on how strongly each factor predicted PAKI, the odds ratios, they gave points.
Okay, a point system.
Yep. Being male got 3 points. Needing that higher dose of norepinephrine also got 3 points. And the other 3, the reoperation, getting more than 6 units of blood, and the anhepatic time over 50 minutes, Those each got 5 points.
5 points for those. Okay. And how does adding up the points tell you the risk?
So you just total up the points for whichever factors apply to a patient. They found that a score of 11 or more was, well, moderately good at predicting AKI. The AUC was 0.70.
AUC, area under the curve.
Right. A 0.70 suggests it's, fair at telling apart who will and won't get AKI. But importantly, a low score, below 11, a really strong negative predictive value, 90%.
So wait, if your score is low, say under 11, you're very unlikely to get AKI. That sounds incredibly useful for doctors.
Exactly. That's a key takeaway. They also broke down the risk. A score under 10 meant about a 10% risk of AKI.
Right.
A score of 11 to 14 pushed the risk up to 26%.
Mm-hmm.
And if the score was 15 or higher, the risk jumped quite a bit to 54%. High risk.
Okay, that paints a clearer picture of who's more vulnerable. But what about the consequences? If someone did develop AKI, how did it affect them?
Yeah, the impact was pretty significant, unfortunately. Those with AKI were much more likely to need kidney replacement therapy, like dialysis.
How much more likely?
29% of the AKI patients needed it. They also had longer stays in the ICU and longer hospital stays overall.
Which means more resources, more difficult recovery.
Definitely. And sadly, higher in-hospital mortality, too. It was 11% in the AKI group compared to just 1% in the group without AKI.
Wow, those are really stark differences right after the transplant. What about later on, over the 5-year follow-up?
Well, interestingly, at 5 years, they didn't see a significant difference in overall survival between the groups.
Oh, yeah.
But, and this is a big but, there was a clear difference in their kidney function. Those who'd had AKI had significantly lower eGFR at 5 years.
eGFR, that's the estimated glomerular filtration rate, a key kidney measure.
Exactly. Their kidney function was worse, about 10 millirelevin, 1.73 milliliters lower on average.
So even though survival rates evened out, their actual kidney health took a lasting hit.
Precisely. And they pointed out that at 5 years, 33% of the patients who had AKI had an eGFR below 60.
Below 60. Isn't that often a marker for chronic kidney disease?
It is, yeah. Compare that to only 19% in the group who didn't have AKI. So it suggests a much higher risk of developing chronic kidney disease down the line if you had AKI early on.
That's a really crucial finding. The study authors also talked about how their results fit into the bigger picture, didn't they?
They did, yeah. They discussed how their AKI rate, that 23%, compares to other studies. They noted there's quite a bit of variation out there.
Why the variation?
Well, partly because different studies define AKI differently. Like, some include urine output measures, which this study didn't have data for.
Ah, okay.
They also talked about why these risk factors might matter. For instance, the anhepatic phase, that time without a working liver, can cause big swings in blood flow and oxygen to the kidneys, potentially causing damage.
Makes sense.
And for the male sex factor, they mentioned some research suggesting male hormones, androgens, might make organs a bit more vulnerable to injury in some situations.
Interesting. And what about their risk index compared to others?
They mentioned other models exist, often using factors like the MELD score that measures liver disease severity or surgery length. Their index, by focusing specifically on persistent AKI and these particular peri-operative factors, seemed especially good at identifying the patients who were at low risk.
And that finding about the long-term kidney function really does seem like a major point.
Absolutely. It really underlines that AKI isn't just, a bump in the road right after surgery. It can cast a long shadow, seriously increasing the risk of chronic kidney disease years later.
Yeah, we should probably touch on limitations too. Every study has them. What did they mention?
For sure. Well, it was retrospective, looking back at old data. That always has limitations. You can't always prove direct cause and effect.
Right.
It was also a single-center study in Mexico City, so, can we apply these exact findings everywhere? Maybe not directly without more research.
Okay.
And like we said, no urine output data for the AKI definition, and they didn't have detailed info on the specific immunosuppression drugs patients were on, which could also play a role.
But they did highlight strengths too.
Definitely. They pointed out it's one of the first studies really digging into persistent AKI, specifically in a Latin American liver transplant population, which is important.
Filling a gap in the research.
Exactly. And they stressed the potential clinical usefulness of the index. Helping doctors spot those low-risk patients could really help focus resources and preventative efforts on the high-risk ones.
Okay, so let's try and bring this all together. What's the main takeaway message from this deep dive?
I think the core message is that persistent AKI is, well, it's a serious and fairly common issue after liver transplants. It messes with the immediate recovery, sure, but it also carries significant long-term risks for kidney health, potentially leading to chronic kidney disease.
And this risk index they developed, while needing more validation perhaps, looks like a potentially useful tool, especially for identifying those less likely to get PAKI.
Exactly. That could help clinicians, tailor post-transplant care, maybe less intensive monitoring for the very low-risk group. And the specific risk factors they found, like the long anhepatic time, needing lots of blood, those highlight areas where maybe we can be extra vigilant or try to intervene during and after surgery.
This has definitely given us a much better handle on PAKI. So thinking about everything we've discussed, the risk factors, the long-term impact, where should we go from here? What are the most promising next steps for research or clinical practice to actually prevent PAKI after liver transplants? That's definitely something for you, the listener, to consider as you continue to explore this really vital area of post-transplant care.